Respiratory acid-base disturbances include acute ventilatory failure, or respiratory acidosis, which it is more commonly called. You should know both names. During acute ventilatory failure, the P big A CO2 or alveolar CO2 progressively increases, while at the same time causes an increase in blood P little a CO2, bicarb, and carbonic acid. This causes the blood pH to drop or become acidic. Let's take a closer look at this. As a person quits breathing, as their breathing becomes less or hypoventilation, the alveolar CO2 rises. This in turn causes the plasma CO2, carbonic acid, and bicarb all to increase. This decreases the ratio of bicarb to carbonic acid, which in turn decreases the pH, as pictured here. Respiratory acidosis has pH and bicarb changes that can be easily identified. The pH drops to less than 735. The PaCO2 rises to greater than 745. Bicarb in an acute ventilatory failure will be normal at first. This is something that just happens. That's why it's called acute. Here are some values for acute ventilatory failure. Please notice the pH of 7.81 is acidotic. It is less than 735. The PaCO2 has risen. It's 80 torr. It is also considered acidotic, more than 745. In this way, I know that the lungs were the ones that caused the problem. Bicarb is within normal limits at 22 to 28 because this just happens and it takes kidneys a day or more to respond. Ventilatory failure is confirmed with these blood gases. Common causes of acute ventilatory failure or respiratory acidosis include chronic obstructive pulmonary disorders. These are disorders that can lead to acute ventilatory failure, like chronic emphysema, chronic bronchitis, COPD. Drug overdose. Drug overdose can depress the ventilation due to narcotics or barbiturates. And general anesthesia. Most anesthetics cause ventilatory failure. That's why patients that go for operations are intubated and ventilated. Common causes of respiratory acidosis and mechanisms. In this case, the pH falls below 7.35, the PaCO2 rises above 745. This is because of retention of CO2 by the lungs, which results in hypoventilation, which eventually will result in hypoxia. Some of the causes are anesthesia, drug overdose, COPD, pneumonia, and atelectasis. Other things that can happen with hypoxia: rapid shallow respirations, a decrease in blood pressure, shortness of breath, drowsiness, dizziness, and disorientation as the brain gets less and less oxygen. Other causes of acute ventilatory failure or respiratory acidosis: head trauma. Severe trauma to the brain can cause acute ventilatory failure. Other neurologic disorders that can lead to acute ventilatory failure include Guillain-Barré syndrome and myasthenia gravis. Renal compensation. In a patient who hypoventilates for a long period of time, the kidneys will work to correct the decreased pH by retaining bicarb in the blood. For example, COPDers with chronic CO2 retention. Their bicarbs will be elevated on ABG when you do a blood gas. Let's talk about acute ventilatory failure with partial renal compensation. The kidneys haven't had enough time yet to fully correct the ventilatory failure. Acute ventilatory failure with partial renal compensation is present when the pH is less than normal range, but starting to drift back to the normal range. The PCO2 is still elevated, and bicarb is greater than normal, helping the pH toward a more normal range. What does this look like? Acute ventilatory failure with partial renal compensation, also called partially compensated respiratory acidosis, is present when the pH is below 735, the PCO2 is greater than 745, and the bicarb is higher than normal. This confirms ventilatory failure with partial renal compensation. However, when is it fully compensated? So let's talk about chronic ventilatory failure with complete renal compensation, or fully compensated respiratory acidosis. Chronic ventilatory failure with complete renal compensation is present when the bicarb increases enough to cause the acidic pH to move back into the normal range. Acute ventilatory failure with full renal compensation shows that the pH is normal but is less than 740. It will not move beyond the 7.40 mark. The PCO2 is high, the bicarb is high. The main thing to remember is that the pH has come back into the normal range, making it fully compensated. So let's talk about alkalosis, in particular respiratory alkalosis. This happens with acute alveolar hyperventilation or a rapid respiratory rate. During acute alveolar hyperventilation, the alveolar CO2 diminishes and allows more CO2 molecules to leave the pulmonary blood. Hyperventilation can be due to pain or anxiety. The action of CO2 molecules leaving pulmonary blood causes a decrease in blood PaCO2, carbonic acid, and bicarb levels. This causes the blood pH to increase or become more alkaline. Alveolar hyperventilation, pictured here, causes the PaCO2 and the plasma CO2, carbonic acid, and bicarb to diminish. It increases the bicarb to carbonic acid ratio, and in turn, the pH of the blood increases. Acute alveolar hyperventilation. Acute alveolar hyperventilation is confirmed when the reported PCO2 is less than 35 torr, the pH is greater than 7.45, outside of the normal range, and the bicarb, or HCO3, is still within normal limits. We know then that this just happened. Acute alveolar hyperventilation is confirmed when the pH is high, 7.55 for example, when the PCO2 is lower than normal, for example, 25 torr, and the bicarb is within normal limits, or 22 milliequivalents per liter. Common causes of acute alveolar hyperventilation include hypoxia. Any cause of hypoxia can cause acute alveolar hyperventilation, lung disorders, high altitudes, or heart disease. Pain, anxiety, and fever can also increase respiratory rate, leading to acute alveolar hyperventilation. Depending on the degree of pain, anxiety, or fever, we may see acute diminishment of the PaCO2, leading to a rise in the pH. More common causes of acute alveolar hyperventilation or respiratory alkalosis include inflammation of the brain. Relative to the degree of cerebral inflammation, hyperventilation may be seen. Another cause are stimulant drugs. Agents that can cause alveolar hyperventilation include amphetamines. These causes can be seen in Table 7.3 in Desjardins. How does renal compensation work for respiratory alkalosis? In a patient who hyperventilates for a long period of time, the kidneys will work to correct the increase in pH by excreting excess bicarb in the urine. For example, a patient that has been mechanically ventilated for more than 24 to 48 hours may have a diminished bicarb. The kidneys take 24 to 48 hours to do their job. Alveolar hyperventilation with partial renal compensation. This is also known as partially compensated respiratory alkalosis. An example of this is a blood gas that reveals a pH of 7.54, a PCO2 of 20 torr, and a bicarb of 15 milliequivalents per liter. Notice that the pH is greater than 7.45 and that the PCO2 is less than 35. Bicarb is also less than 22. Alveolar hyperventilation with partial renal compensation, it's just starting to help, is confirmed. So what about when there's complete renal compensation for chronic alveolar hyperventilation? This is also called fully compensated respiratory alkalosis. Fully compensated respiratory alkalosis is present when the bicarb level decreases enough to return the alkalotic pH to normal. For example, a pH would return to 7.45, just within the normal range, with a bicarb of 14 milliequivalents per liter. In respiratory alkalosis. example of a gas with a blood gas that you may see with fully compensated respiratory alkalosis or chronic alveolar hyperventilation with complete renal compensation is below. The pH would be 7.45, which is within normal limits. The PCO2 would be 20, which is less than 35 torr. The bicarb would be 15 milliequivalents per liter, which is less than the normal 22 milliequivalents per liter. As a general rule, kidneys do not overcompensate for an abnormal pH. They bring the pH just into normal range. If a patient's blood pH becomes acidic for a long period of time due to kidneys will not retain enough bicarb for pH to climb higher than 7.40. Another general rule of thumb is that the opposite is also true. If the blood pH is alkalotic for a long period of time due to hyperventilation, the kidneys will not get rid of enough bicarb for the pH to fall below 7.40. Generally, they come just into normal range to 7.45 or 7.44. One important exception happens in people who chronically hypoventilate for a long period of time. It is not uncommon to find a pH greater than 7.40. For example, 7.43 or 4.4. These are patients with chronic emphysema or chronic bronchitis that have lived with this condition for a long time and are fully compensated by the kidneys. Another exception is due to water and chloride ion shifts that occur between intracellular and extracellular spaces when it works to compensate for decreased blood pH. This can cause overall loss of blood chloride, resulting in hypochloremia and increased blood pH. To summarize, lungs play an important role in maintaining the PCO2, bicarb, and pH levels on a moment-to-moment basis. Kidneys play an important role in balancing bicarb and pH levels during long periods of hyperventilation, increased respiratory rate, or hypoventilation, decreased respiratory rate. We've come to the end of our talk about respiratory conditions. Thank you for your time and attention. Next, I'll talk about metabolic conditions.